So I'm here to tell you when that goes wrong with a lovely case study of when that went wrong. So absolutely, it's important to assume capacity. This case study is about one where the patient didn't yet have a diagnosis of dementia. So I'd met him before, lovely gentleman, really poor eyesight. He had a wound on his leg. So we'd been asked by the GP saying, can we have a look? And I was like, no problem. He's just not wearing enough socks. Fantastic. Put on some more socks, and sent him on his way. So then they got back to us that it hadn't healed, and we have a wound care pathway in Wales. So we have to datex any wounds that come through, do standard reviews, etc. with these people. So we brought them in, and I was like, okay, he's still wearing the one sock. Let's put in a leather lining. You know, no problems. Patient's alert. He knows exactly where he is. He doesn't know who I am, but he knows I'm one of the prosthetists. That's fine. I'm another Scottish prosthetist in a Welsh centre. Probably not nothing to be worried about. And then what happened is he started falling a lot. So we referred to the falls team and referred back to the GP. The patient's always there. And then he came back with more problems, more falls, more wounds, bits of food in his leg. Um, and slowly over these times, you start realizing that, yeah, okay, he's alert to where he is now, but is he alert to where he is when it is? So we've been talking a lot about him as a team, and I was like, could we perform a mocha? So I thought it was a memory orientation cognition assessment. Susie says it's the Massachusetts or something.
Montreal
Montreal
cognitive assessment.
cognition assessment. You'll have something similar in your area of work. So you've got to score 21 out of 25 to be considered normal, with no memory issues whatsoever. Given that this patient had eyesight concerns, we knew it could be slightly lower. They scored 2. They couldn't do basically any of it at all. So we spoke to psychology, which would be our normal referral route for anyone that we're worried about their memory. And they said it's actually so low that they wouldn't accept a referral. So we got back to the doctor, and now we've done some sort of standardized testing. They listened to what we had to say. So this patient was actually hospitalized the very same day. Turned out they had a urine infection as well, and they had got their diagnosis of dementia, and they moved to a care home. And actually, the outcome for me is really pleasant. It's really positive. They barely ever need to come in anymore. They've got no problems. They've got all the assistance that they need. They've had no wounds. Their weight's not fluctuating. They're not falling. Yes, they've lost some of their things, some of their independence, but he's in a safer, much more nurturing environment where he's doing much better. And part of me is like, well, if only I assumed he hadn't had capacity at the start, we could avoid these pitfalls. But he was managing, and he was doing everything at home he's meant to, and we followed everything exactly as we should, and there was an outcome to that, and he got his diagnosis, which without us he wouldn't have gotten when he did. If we move on to the next case study, um, so we're talking about a patient who is actually the patient's wife who has dementia. So they're a very codependent relationship. So the patient comes down to the appointment as a prosthetic user, and the wife always comes with, and is physically able to do things, but mentally needs that prompting and support. So this patient had been a prosthetic user for a long time, but as time progressed, we noticed that, for example, the wife got lost in the building. If she went to the bathroom, she couldn't find how to get back. So suddenly we are now, when she comes to appointments with him, having to put in steps to make sure that she is safe in our building, that she can find our way back. Instead of saying they're in fitting room 1, being like, okay, everyone in the building is aware that she is in, or do we need someone actually to come with them? So family members. As time went on, we found that actually she was being verbally aggressive, not to us, but the patient was starting to open about these issues that were going on. And unfortunately, it became the skin breakdown. What's going on here? Why is this happening to you? Nothing has physically changed with your health. Turned out he's wearing the limb 24 hours a day. Well, why is that? Why are you suddenly sleeping in it? And part of it is because his wife is no longer able to help in the way that she had, to be able to go to get the legs, to put them on. But actually also turned out she wasn't just being verbally aggressive at this point. She was being physically aggressive to this patient. So it was so that they were able to get out of the way and be able to move. So then it's about risk management, isn't it? And this is where it gets very complicated. This isn't just risk management, you know, you might gap and fall over. This is a whole can of worms that realistically no one wants to be having come into your clinic and have to open. And I'd love to be able to say that it all turned out lovely, but actually the outcome in this case is that we knew the family were involved, we knew social work was involved, and you have to follow those things. But sadly, the patient actually slipped, broke his hip and died. So this is a primary patient that came through a few years ago, and he was fitted with prosthesis, and he walked amazingly first time, fantastic. Because of his dementia, he almost forgot to overthink it. Walked brilliantly. Um, so later on, once he changed a little bit, he wasn't eating as well, he was losing weight. So we fitted a check socket and I put it on a multiflex foot. So really soft toes, whereas he was used to a stiffer one, and he nearly fell. Because again, he's walked the way that he's always done, and this was just far too soft in the toes, and he was not able to adjust for that, which was something I hadn't expected. We then had repeated appointments for him. There was pain whilst going through some of the later physiotherapy sessions. And communication difficulties meant that we didn't realise for quite a long time that actually it was phantom pain that they were talking about, not related to prosthetic use. Because you're like, do you have it at home? He's like, no, no. Whereas actually when you speak to his wife, yes, yes. So that took quite a while, but we had a education review and there's been no other issues since then. I say no other issues, so other changes. Again, we've had a few issues with weight going up and down, so we've got a dietitian involved, and that's really solved things. And dexterity's gone downhill a little bit, and vision. So we ended up changing from like a standard gel knee sleeve onto one of the Juzo ones and put the little loops on it. A nice bright colour, not yellow, but I'm going to use yellow in the future. So they can pull the tabs up, and he's doing fantastically well. He's probably one of the most active users I've got.